Professor Chittadini for the invitation to speak to you today. And what I'm going to do is take you on the journey of cryopreservation in its developments in ART. And I think it's, for embryologists, it's quite important for them to have an understanding of how this area has developed and how to then apply it in their clinics in their future today. So I'd first like to start with sperm cryopreservation. Although there's been really no developments since the first method with sperm cryopreservation, there were some really important discoveries in cryopreservation using sperm, and that was that sperm could survive at temperatures below zero. That if the sperm cells were dehydrated or water removed from them before freezing, that survival was better. And this was initially using sugars to dehydrate them, but then later using glycerol. And that was one of the really important discoveries in cryobiology. Then following on, there was an important discovery that sperm would survive at temperatures at minus 196 degrees Celsius. And this really started this whole concept of us freezing material in liquid nitrogen. And then subsequently, there were 3 pregnancies reported following the insemination with frozen sperm. And that's really been the procedure that has been adopted and kept pretty much intact for over 60 years for sperm. For embryo cryopreservation, the first report of a live birth was in 1972 by Whittingham, and this was following the transfer of mouse embryos that had been frozen using the cryoprotectant DMSO in a slow freeze method. In 1983 and 1984, Trounsend and Moore and Zellmacher published that they'd achieved pregnancies following cryopreservation of human 8-cell embryos. And this again was using slow freezing with DMSO. And at that stage, we were freezing embryos in glass vials. These were really dangerous to use. They would explode when they were brought back up to room temperature, and you'd lose the contents of the embryo that you'd frozen. And so there was some development in the animal bovine area of plastic straws. And in 1985 and 86, Lazal and Testar reported the first births using a different method of cryopreservation where they used propanediol and sucrose. But for many of us, the important change that occurred was that they were using plastic straws to freeze their embryos. And so we quickly adopted this method, one, because it was going to, at least even if survival was lower, that we would actually be able to recover the embryos. And this was an important change that occurred. And the method that they developed then with the propanediol and sucrose really became the standard method for freezing for almost 20 years without change. And it's interesting that at much that same time, and I think 1985 was a really pivotal year for IVF developments, that there was also the first report of vitrification of mouse embryos. So what lessons have we learnt from the cryopreservation of cleavage stage embryos? We know using that method of 1.5 molar propanediol and 0.1 molar sucrose, that embryos that survive fully intact have a similar implantation potential to their equivalent fresh embryos. This really was fundamental studies that showed us that cryopreservation in itself wasn't having an impact on the subsequent development of the embryo. But if blastomeres were lost during the thawing process, that they had a reduced potential. And you can see quite clearly here in the comparison where all of the blastomeres are intact compared to down here where we lose 2 blastomeres, that the implantation rate has almost been halved. So blastomere survival will determine the effectiveness of cleavage stage embryo cryopreservation. So using this method, we can see that around 50% of the cleavage stage embryos were surviving fully intact and this was again reinforced by Balaban's study. We had then done quite a bit of development on changing sucrose concentrations in our oocyte freezing, and we then decided to also change the embryo cryopreservation procedure at that stage. And we increased the sucrose concentration to 0.2, but also changed the freezing protocol into doing just a single step. And you can see here that it improved survival of these fully intact. Up to 80% of the cleavage stage embryos survived fully intact. And this was obviously an improvement that was going to give us more embryos for use in the clinic. But at much the same time, there was the introduction of vitrification to the clinics, and in the cleavage stage at least, you could see here that they were also obtaining around that same sort of survival rate of around 80%. What were the developments for blastocysts? Well, in, again, 1985, this year again, really important year, Jacques Cohen published the first pregnancy following the cryopreservation of a human blastocyst. Again, this was slow freezing with a different cryoprotectant. This was with glycerol in this situation. And many groups tinkered with this method, trying to actually get good results with the glycerol procedure for blastocysts. Unfortunately, many of us couldn't actually achieve good results with this, and for that reason, a lot of clinics at that time really stuck with just cleavage development, so day 2, day 3 development, and the freezing of day 2 and day 3 embryos, really because to get the best outcome for their patient, that was the only freezing method that was working well in their hands. But there were some groups that could actually achieve good results with that glycerol method, and here's Kuwayama's results with the slow cooling with glycerol, and also Lieberman's here, where you can see very high survival rates that they could achieve. But again, as I said, at that time, there was this introduction of the vitrification. And you can see here that in some groups, they could also achieve high survival with the slow freezing and also with vitrification. And these were two really important studies where it showed that in some groups' hands, they could actually achieve very good results with both procedures. This study clearly shows here that when we're doing single blastocyst transfers, that the fresh compared to the vitrified, when we stratify for, again here, the grading of the blastocyst, that you can see that similar pregnancy rates can be achieved with their vitrified compared to their fresh through each of the grading stages. So you can see here that we had then come to the stage where we could basically say the vitrification wasn't having an impact on the blastocyst subsequent development in the uterus. This was then expanded into a bigger study. You can see large numbers here, and this is a large cohort study where the clinical pregnancy rate for their fresh and their vitrified is similar. We've also shown that with the closed vitrification system that we can also achieve high survival of the blastocyst, but that we can also achieve similar implantations to our fresh with the closed vitrification. So in this day and age, we know that now vitrification, that the slow cooling and even closed vitrification all can achieve fairly high survival rates across the board for blastocysts. And so really we can come with a conclusion now about embryo cryopreservation. It really did make a huge significance in the whole area of ART, and that was mainly because it gave us the opportunity to maximise the pregnancy potential from a cohort of oocytes and embryos that came from a stimulated cycle. And this was really where it made a huge difference in our clinical treatment of patients and the way that we organised our whole program. that it minimised the risk of multiple transfers. And we now see that many groups, or most groups in the world, that are now adopting single embryo transfers, that this is really where cryopreservation becomes a really important component of our ART system. And it obviously, therefore, by reducing multiple pregnancies, it becomes a safer process and far more efficient. So I want to spend more time on oocyte cryopreservation because this is really where I was working at that time. And you can see here, this is the first birth from unfertilised oocytes in 1987 by the German group Venom. There were others working on oocyte cryopreservation at that stage, but again, they were using slow freezing with the cryoprotect and DMSO. And the survival was very low, down around that sort of 20% survival. They also observed very low fertilisation rates, and this was often thought to be due to zonal hardening, which is a concept where the cortical granules are spontaneously released and change the zona properties. They also observed high rates of polyploidy, and there was also concerns regarding a high rate of aneuploidy because of the spindle being fairly susceptible to changes in temperature. And really at that stage, most groups abandoned the whole concept of freezing oocytes for clinical use. At that stage, because we had done quite a bit of the work using the slow freezing 1.5 molar propane diol with 0.1 sucrose for embryos, that I decided to change across and see whether this actually was appropriate for oocytes. And we showed with donated oocytes from our patients that we could achieve around a 50% survival with this method. That it had normal spindles were present within these oocytes, and in fact we actually observed that propane diol had a protective effect on the spindle, that there was no spontaneous release of the cortical granules, and therefore we felt that fertilisation would be able to occur. And then in doing some of the work that I did in California and also in New South Wales, I could show that normal fertilisation did occur in these oocytes, and that chromosomally we didn't appear to have this increase in aneuploidy that had been thought would occur. And in some work that I did in California, I then grew these oocytes, froze these oocytes, fertilised them, and grew them out to blastocysts. And this was, interestingly, some of the first blastocysts that one of the registrars working in the clinic in California saw, and his name was Andre Barini, who became then a big champion of oocyte cryopreservation. So in 1994, we established the world's first egg bank in Melbourne. This was really for young women who were requiring fertility preservation due to a pending cancer treatment. And we froze both oocytes and ovarian tissue back at that time in 1984 for these patients. We knew that because these patients were cancer patients, there was going to be a long delay in thawing oocytes, and that really we weren't going to be able to validate our procedure at our clinic to the pregnancy level. But we were aware that there was changes afoot with the law in Italy, and so we started a collaboration with Eleonora Porcu's group in Bologna. Using this method, the 1.5 molar propane diol and 0.1 molar sucrose method in slow freezing, Eleonora's group then reported the first birth in 1997. Following on from some of the work that we had conducted where we increased the sucrose concentration, Raffaella Fabri then also increased the sucrose concentration in their clinical group, and they increased it to 0.3 molar. And this was really to improve survival. But one of the problems with increasing that survival was that they did observe that it had an impact on their subsequent implantation. And implantations at that stage were almost half that of the fresh oocytes. So at that time, we had worked mainly using the 0.2 molar sucrose, and it took us quite a long time to actually get enough pregnancies to start and publish this work. But at a similar time, Veronica Bianchi in the Bologna group also looked at increasing the sucrose concentration up to 0.2, and you can see here that we could both achieve a higher survival. Remember, the previous survival was only around 50%, and that we could then show that the implantation rate for the cryopreserved was similar to the fresh. So now let's look at the vitrification of mature oocytes. And the first birth was reported using fairly high concentrations. This is a really high level of ethylene glycol and a high level of sucrose. This was reported by Kuleshova in 1999, and that was work that was conducted in Gianaroli's clinic in Bologna, and then I think was not, unfortunately, that was the only pregnancy that they got with that procedure. There were other case reports at that time, again using very high concentrations of ethylene glycol, and these were from the Korean groups and also from the Japanese groups. And again, at that sort of time, we were seeing this new development of some of these tools that were becoming available away from the little grids that had previously been used for blastocyst vitrification. And then there came out a couple of series where they had reported a number of pregnancies using this combination of ethylene glycol, DMSO, sucrose, with the new tools that were coming on the market, the CryoTop tool. And this really changed the whole area of oocyte cryopreservation. These were the first, these authors really were the innovators in this area, in trying something that was very different and very new with oocyte vitrification. But the most significant report, and this is really the very important report, was from Anna Cobo. And this was in 2008, where she showed with using donor oocytes that they could achieve very high survival rates following vitrification using that combination of ethylene glycol, DMSO, and sucrose, and that they saw no impact on fertilization, embryo development to the day 2 stage, and even out to the blastocyst stage. They then went on in a bigger series to also report that they could maintain that survival and that the implantation rate was similar to the fresh. And this really changed the whole area of oocyte cryopreservation. Other groups have also shown similar survival and that they can obtain equivalent results to their fresh with their vitrified oocytes. You can see here. And the Cobo group has also shown that there's been no increase in major or minor malformations in their perinatal outcomes from these. And I think this was where we now should be very confident in vitrifying oocytes, that there are normal babies born and that there isn't an increase in birth malformations, which was originally one of the major criticisms of oocyte cryopreservation. So we've come a long way since that. So the Cobo group has also shown now that there looks like with their infertility patients that there may be a little impact on survival with the age of the woman and the age at which they're collecting those oocytes. We have also shown that we, in our hands, at least with a closed system, that there doesn't seem to be an impact of age on the survival of these oocytes, and that we can again obtain, at least in this group, a similar implantation rate to our fresh. So technology in cryopreservation has really come a long way now. We know now with the introduction of vitrification that we can achieve very high survival rates for oocytes, cleavage stage, and also for blastocysts. That the cryopreservation hasn't had an impact on their subsequent development or their implantation. And this is really critical to the, where we sit now with cryopreservation and ART. So the other area that I'd also just briefly like to talk about is the ovarian tissue cryopreservation. And I know we'll have speakers tomorrow that will talk about this, but I really wanted to talk from the cryobiologist's frame of mind. And really, ovarian tissue cryopreservation really came into a possibility with that first paper published by Gosden and Baird back in 1994, where they showed that they could restore the fertility in sheep using frozen ovarian tissue. We were working at the same time with human ovarian tissue, and we then subsequently showed that we could preserve the morphology, at least, of these primordial follicles, the oocytes, but we also looked at the mitochondria within these oocytes and showed that we were maintaining the integrity of those mitochondria, at least at the level of morphology, following our freezing procedure. We then showed that following xenografting from a number of patients, that tissue, that we could obtain reproducible preservation of the ovarian tissue and the follicles in those. And I think, you know, one of the critical points from a cryobiologist is that we can actually show directly that we've got clear evidence of preservation of the material that we're trying to cryopreserve. And this is a study that we did, or a report that we presented, where the patient had had a bilateral oophorectomy. We had frozen ovarian tissue and transplanted it back to the patient. The patient then subsequently, we obtained oocytes from her. These developed to embryos, and she gave birth to twins. And this is unequivocal evidence of preservation of primordial follicles with the freezing method that we've used. There's vitrification is now starting to also be used for ovarian tissue, and that the Japanese groups have now obtained a couple of births following the vitrification of tissue. So in summary, cryopreservation underpins all of the improvements that have really occurred in ART. Vitrification has revolutionised cryopreservation in ART. With optimal methodology, we can now say that oocytes, cleavage stage embryos, and blastocyst cryopreservation can actually achieve comparable outcomes. That outcomes following cryopreservation are equivalent to fresh, and that really cryopreservation is not impacting on the development of the embryos and implantation. The blastocyst, I think, now is our preferred stage for vitrification and for cryopreservation, giving us a more accurate prediction of the stored pregnancy potential. Oocyte cryopreservation has now become integrated into a routine procedure in most laboratories in the world. And ovarian tissue cryopreservation has now, with numbers of pregnancies, and the guys tomorrow will show some really nice data on the development of a large number of babies born from this procedure, that it's now time to remove the experimental label on ovarian tissue cryopreservation. So thank you.
Ladies and